This is the Zemar Podcast. Elite Benefits of America helps small and mid-sized companies with their health insurance programs. And now, your host, Butch Zemar.
So welcome back to the show. I have a special guest, Gary Blaum, and he's going to share some insights of his experience with the self-funded world, pharmacy, benefit managers, and some ideas that employers could actually start getting ahead of the curve. Thanks for joining me, Gary.
Nice to be here.
Hey, Gary, we've talked about your background quite a bit, and you have a lot of experience in the self-funded world and the third-party administration world, TPAs. Can you give our audience just a little background on where you come from and what some of your expertise are and where you're at today and what you're trying to work on?
Oh, sure. Well, thanks for the opportunity, first of all. But over 20 years ago, I was working for a large property and casualty and benefits house. Mm-hmm. And I said to the ownership, I think we really need to build a third-party administrator. And I had background in the benefits and claims side of things. So they bought that and we did that. Spent a lot of time working with providers, hospital systems, building out systems and networks for them, and then working with the self-funded employers in their communities to help everybody. Mm-hmm. That worked out really well. But after about 20 years or so, I kind of got a little tired of it. Mm-hmm. The government wound up becoming more and more involved, and I didn't like that. So I decided to move on. But one of the things that drove me bonkers in the TPA world was the PBM problem. I knew that the PBMs were telling us one thing and delivering something else. Mm-hmm. So I would always sign our national contracts for the various PBMs we worked with, and I would always say to them, all right, I'll do this, but you're going to agree to give me an Excel spreadsheet claims file every 3 months so I can check the numbers. And they agreed, because otherwise I wouldn't sign the contract.
Sure.
And I'd get these things, and when I'd go to work on them, it was obvious that what the client was paying was far different from what the contract supposedly guaranteed. Mm-hmm. So I got to the point where I realized what was going on. I got in touch with some people on the West Coast. I'm out in Pennsylvania, by the way, about 50 miles outside of Philadelphia. Got in touch with these folks on the West Coast who were experts in PBM contracting. So we went out and we worked with school districts and other types of self-funded employers to help them understand how that system was working and why it wasn't working for them. That was very successful. And we did a lot of work, a lot of business. But as all things, today, everybody's a PBM expert. Every brokerage house has their PBM people. There's so many cost containment companies in the PBM space. I said, okay, time for me to move on again. And when I did leave the TPA, I said, I'm not going to work for anybody. I'm going to be independent. I'm going to do what I want to do, and I'll do it my own way. And that's the way I've kept it. What's happened over the years is that as time goes by, people I know across the country oftentimes will call me and say, look, can you help us distribute this new concept? And I'll take a look at it. And probably, 9 out of 10 times, I don't like them. There'll be something in it that I think isn't meeting the fiduciary obligations or just isn't going to deliver what the clients are looking for. So I thank them respectfully for giving me the chance, but I move on. About 4 years ago, I got involved with some folks in Maryland who were related to the PBM work we had done. And this was a large school consortium on the eastern shore of Maryland. And one of the things that they don't have over there is primary care. There just aren't many doctors in that whole area, and it's a big geographic area. So what happened was a broker that I know brought in a clinic company, Everside at the time, now part of Marathon, and they set up an in-house or an on-site clinic. It did extremely well. The people were thrilled. It just worked out great. So I started working a little bit with Everside and saying, look, I'm going to try to help distribute the concept because I believe in it. And at the same time, I ran into some folks just south of me, here in Pennsylvania, there are things called intermediate units. And what those are, they're school organizations that support special ed, they do buses, they do all sorts of buying things for school districts in their counties. But they can be pretty substantial employers themselves. This one, Lancaster, Lebanon, is about 1,600 employees. So I got to meet the business director, went down and visited with him, and he couldn't stop talking about his clinic. And at the end of the visit, we sat in his office, and I said, "You're so convinced. Why?" And he shows me an Excel sheet, a chart showing, at that time, I think it was probably 6 or 7 years of experience. And of course, I've been in this game a long time, and I know the primary game. And when you're talking to a client and you're trying to justify things, you say, "Oh, it's the trend." The trend. That's a smokescreen. That's what he was beating by a mile. So I worked with him a little bit. I took his numbers, I recreated the chart, and since then, every single year, he sends me his updated numbers. Now, last year, he says to me, "I had a bad year." Yeah, right. He had a bad year by his standards, and yet he's still so far under what the trend would have said he should be spending. It's incredible. So that prompted me, with the thing I had done or had seen in Maryland, to really spend a lot of time soliciting on-site or near-site clinics. But what I found out pretty quickly is that that only fits in a small minority of employer situations. And the reason it only fits in a small minority is that the requirements to make it work are such that unless you're going to be able to deliver maybe 1,500 people, unless those people are regionally centered, geographically centered, so they can get to the clinic, and unless you're willing to pay the upfront or make the upfront investment to build out a clinic, which can easily be $1 million, it just doesn't fit. So most employers are just not in the market or even capable really of doing an on-site. Yet, as far as I'm concerned, that's probably the most effective cost containment device ever built. So I'm looking around and I'm getting a little frustrated because I know what these things can do and there's just no way to do it. I get a call from some people that say, "You need to take a look at this program." And I said, "Okay." And initially, I thought it was a telemedicine program. And telemedicine's fine. Wellness programs are fine, but neither one of them work very well. So when I talked to the people, they said, no, we do have telemedicine. That's a key component. Yes, it's part of it. But that's not the real component. The real differentiator is these folks deliver primary care directly to the people, regardless of whether it's at their home, or maybe the employer has a separate office or something, but they'll work it out so it's convenient to the people. I said, okay, that's different. I like that. And the care is delivered by nurse practitioners who are primary care trained specialists in that field. The nurse practitioners are then backed up at the home office by a staff of primary care physicians. So, in fact, I have a personal relationship with this concept. I have my own personal health insurances with United Healthcare. And every year, United calls me or sends me a note and says, it's time for your annual exam. Well, that exam is not done by my PCP. A nurse practitioner comes to the house. And they were just here 2 weeks ago. It takes about an hour. It's a full primary care style visit. In fact, this time I had a couple of tests done that I didn't even know they existed. An instantaneous HbA1c blood test and a test to tell me whether or not my blood flow from the heart to the feet is working right. I was very impressed with that. So the reason it's so valuable and the program makes so much sense, there have been studies done that say 80% or more of all people prefer in-person visits over virtual. Well, that makes sense. You're just not creating a relationship, even though you may be looking at someone on a computer screen. It's just not the same. So the model, that's the key component, as far as I'm concerned, of the difference. That's why it's unique. Now, the way it's structured, I often say to people, there's no good reason not to do this. And they'll look at me like, yeah, right. Well, it's true. From the standpoint of the employees, they absolutely love it. And the reason they love it is included in the program from their perspective are the visits, whether they're virtual or in person, at no cost, the lab work necessary to support primary care at no cost, and there's a formulary of about 1,200 generic drugs at no cost. So the patient, for the first time in I don't know how many years, is being given a new benefit that's first dollar. No copay, no deductible, no coinsurance. Most of the employers who do this don't charge any kind of contribution for it. So it's a wonderful tool from that perspective. The employees, like I said, they just absolutely love it. When CFOs get to understand what this is all about, they love it too. And the reason is they come to understand that there are two big problems with the healthcare system. One is fee-for-service medicine, and the other is the incidence of chronic disease. Well, what does this have to do with fee-for-service medicine? You know, when I describe that system, I always tell people, look at it like it's a pyramid. At the bottom of the pyramid are the employers and the covered people. They're the ones who put all the money into the system. On one side of that pyramid are the docs, hospitals, all the medical providers. On the other side are the carriers, the networks, the PBMs, all the vendors that are supporting healthcare. Well, that's a big load for the employers and the employees to carry. And it goes up every year because it will, and it's designed to. Everybody on both sides of that want increasing revenue. It's just human nature. Some of them want it for the wrong reasons, at least as far as I'm concerned with health insurance, like PBMs that are stock-based, equity-based. That's purely profit necessary. So that system is always going to put pressure on the cost of care. It's never going to stop. And until something cataclysmic occurs, it won't stop. So if you can take claims out of that system, you can automatically save a small fortune because you avoid all the administration. You avoid all the overhead. You avoid the profit incentive. It just works. So the way this program works, the employer pays a fixed monthly cost per covered employee. Okay? It's going to be in the $30 to $36 range, generally, depending on the circumstances. So it's a fixed premium. Now, I always say to people, why is that important? Well, it's important because if you can drive utilization and get as much care as possible in there as opposed to in your health plan, the cost goes down per unit. The more units, the less cost because the premium, it's not a premium, but the fee is fixed. So when CFOs understand that, and then they understand that there's a lot of data suggesting that you're going to reduce the overall cost of the plan by a minimum of 10%. Well, now you've got, there are three primary issues in selling healthcare programs. One is, does it fit the employer? Well, if the employer is making huge amounts of money and doesn't care about profits or costs, well, no, it doesn't. Nothing fits. He's just going to pay the bill. But for the rest of us, that's generally not the case. We're looking for ways to control this. Well, the second thing is, what's the risk? Is there a risk for just doing it? HR people are notoriously concerned about that. I don't blame them. Well, not really with this, because one of the nice things about it is it's totally divorced from the underlying health plan. Has nothing to do with the underlying health plan. Doesn't disrupt it, doesn't require change, doesn't impact it except by removing claims from it and replacing it in a lower cost environment. The third thing is the price. Well, and that's where the CFO gets concerned. And what we can show them is based on the fixed cost, based on a very strong actuarial analysis, and based on an awful lot of studies done about primary care and what kind of savings it drives, the odds are they're going to reduce their cost by somewhere around 10 to 14%. Well, now all of a sudden we're talking about going down as opposed to going up. So again, as I often say, there's no good reason not to do this. The HR people love it. It's a recruiting tool. The people covered love it because there's no out of pocket. And the CFOs, once they understand it, they love it because for the first time, they can project perhaps some savings, real savings. I mean, I can't tell you how many single point solutions I've looked at who claim savings, but at the end of the day, it's real tough to validate that, So all in all, the program hits a lot of the buttons. It gets to the fee-for-service problem. It's great for the chronic disease problem because by having routine, ongoing preventive primary care, you start to diagnose things early. You don't wait until they become complications. Probably 80% of all the money that's spent on chronic disease is for things that were in fact preventable if there had been early and thorough diagnosis. So the program, it's a company called Vitable, Vitable, makes just a lot of sense. It's unique, it's different, but it's focused on those areas where our problem really resides, and that's in fee-for-service and chronic disease. So I'm blabbing along here. I don't even know how long we've been talking.
That's all right. So a quick question. Early on in what you were talking about, you were saying that like telemedicine doesn't hit the mark. And so obviously telemedicine or telehealth or whatever you want to call it, teledoc, has been there for a long time, and it really kind of ramped up during COVID because people weren't going in and visits. But so some people are like, well, that's the solution, right? So I guess, can you explain some of the downsides of the telehealth program of why it wasn't working and saving money on the group plans?
Yeah, it's primarily utilization issues. During the COVID process, in fact, I just talked to a school district on Monday of this week, and he loves this concept, but he was thrilled. He got, by luck, he took on a telemedicine program just before COVID hit. And absolutely, that made a great deal of sense. But now we're kind of out of that, and we go back to the situation, as I said before, the vast majority of people prefer in-person healthcare as opposed to virtual. And when you look at, most of the telemedicine organizations publish their utilization rates, and they're just not very good. You're lucky to get 20% of the covered population utilizing the program. It just doesn't happen. So this program, on the other hand, is more like 120% utilization because, and they know this, the only way they're going to survive is to be able to deliver a couple of things. Number one, utilization rates and savings. Well, the more utilization, like I said before, the less money goes into that fee-for-service bucket. Those are easy dollars to justify. And the actuarial study will show you that. So, I'm not saying that they're bad systems. They just don't have all of the steps, all of the services built in. And plus, most of them, related services, drugs, labs, all of that, they're at the expense of the employee or the health plan. That's not the case here. All of that stuff is built in. So it just generates a more successful product to be able to get into the hands of the people who really need it and who want it and where it works.
Got it. And so employers that might be interested in this, and just kind of explain it a little bit more detail, right? And so in a traditional health plan, we're paying premiums into a pool, right? And so there's a profit and loss statement, just like any other business, right? So there's money coming in and there's money coming out, right? And so as utilization increases on a health plan, a traditional one, and just in general, is obviously there's money coming out of that, right? Insurance company still needs to make money. They still have other expenses that are not even factored in. Some people think that, well, if they didn't pay out more than what they took in for premiums, they're ahead of the game, but obviously that's not the case at all because they're I mean, sure, they're in profit business just like everybody else is. So, but it's got to be strategically planned. But it's about the utilization, right? So it's a profit and loss statement essentially. And I'm being very generic on this terminology just to make some of the businesses that are listening to this maybe understand it a little better. And what this concept is doing is saying, hey, the employees may or may not be utilizing it the best way they can or at all. And so what we can do is, all right, well, getting access to care immediately could save a lot of money later. And then also the ease of it, but let's try to put it in a different bucket so that the utilization or the profit and loss statement changes. It shifts to a different profit and loss statement that's geared towards that kind of utilization. And so, but can you give a little bit of clarity though? An employer, large or small, that says, "Hey, this is great. Like, how do I do it?" Right? So, what are just a high level overview? Some of the steps, what occurs about getting a facility there with physicians in place for the employees? How does it? Just give a picture of what that looks like.
Yeah, the way it works. Again, the physicians are based probably remotely and at the home office. The nurse practitioners are based at their homes. Mm-hmm. So each nurse practitioner has a mileage radius that they're going to be involved in with people who are covered in that radius. Mm-hmm. So if Jack Smith says, I think I might have pink eye, I'd like to have somebody come out, or I might need my annual exam, he's going to contact the nurse, and not generally the same day, but very soon thereafter, the next day or the day after that, they'll have their own appointment and she'll come out and take care of that. So that capability, that flexibility makes it very simple for people to gain the care they want. So some people will say, well, it sounds to me like you're going to drive a lot more care. Isn't that going to raise my costs? And as I said before, we know from the actuarial analyses and from stop loss, we've got, I think it's 17 MGUs and stop loss carriers now, who, if you do a stop loss quote, one side says without Vitable and one side says with Vitable, the expected claims cost is going to be 10 to 15% lower with Vitable, because they know that the gross claims overall are going to come down because of replacing the fee for service with a fixed fee model. So I'm not sure I'm answering your question.
No, 100%. What you did is definitely, for some reason, I was painting a picture because one big trend, or I don't know if it's big, but there's a trend where large employers are building facilities right on campus, right?
Yeah.
And that's huge. But that's a whole nother level, right? But you're talking about, hey, you could be a mid-sized company. Don't worry about putting up the shack and putting physicians in there. What you're saying is, hey, we have a service. Like you said, a fee, you're paying a service fee to a provider for all your employees, and then they schedule appointments. So it's like going back in time, and correct me if I'm wrong, it's kind of like going back in time when doctors made house calls. But nurse practitioners are now going out, probably because just the way the model has been made. And so nurse practitioners are coming out and doing this in the comfort of your own home, just like they did back before World War II, where doctors would make house calls, right? And so, but the whole purpose of this is to shift the profit and loss statement to a model that says, okay, we know we're going to be paying this out, so let's build a model where we charge enough and the company makes some money and everybody, the overhead's covered, and we pay this nurse practitioner to go out to people's houses. Not everybody's going to use the program, but someone will say, well, that's easy, and I could just schedule it on my own calendar, and they could come to me, right? And so it changes and makes it a lot easier. I could see how the utilization you mentioned, like in a telehealth might be 20% utilization in an employer group, so the employees are only using it 20%, or 20% of the employee base is using it. Right. Now all of a sudden, now you exceed that because now more and more employees are like, well, I could keep repeating this process because it made it simple, and they're shifting that cost factor to utilization to somewhere else. But now, can some of these nurse practitioners diagnose and then maybe prescribe medication for a lot of simple stuff? And what? Okay. Oh, yeah. And when is it? Yeah. When's the tipping point where they need the nurse practitioner? Maybe? That's a
great point. I'll give you an example of a great story I know about, and in an on-site clinic. but it would happen here too. It does happen here. And again, this model, the Vitable model, includes every resident of the household. There's no additional fee for dependents.
Mm-hmm.
So, so in this case, what happened was an employee brought a dependent daughter into the clinic. Well, same thing could have happened, have the nurse come to the home. They ran the blood tests, and the nurses, and normally in the clinics, the physicians aren't there. Those are all nurse practitioners as well, but with physician backup.
Mm-hmm.
So they ran the blood tests. The nurse sees the blood test. She says, uh-oh, I don't like this. She refers it to her physician.
Mm-hmm.
The physician says, all right, we need, in this case, likely we need an oncologist.
Mm-hmm.
We are talking about a young lady who's probably got some form of cancer. Now, what Vitable does, they will become very familiar with the underlying network. They don't really care about the benefit plan, but they want to know who the network is that the employer is using so they can be helpful with the employees and help refer them appropriately in network. Now, if they have to go out of network, you go out of network. But normally you can use, the Blue Crosses, the Aetnas, the Cignas, the United, they've all got these enormous networks now. So they will take the role of trying to help the person find the right level of care for the next step. They can't do it themselves. No primary care can. They've got to move them on. Well, that's fine, but in this case, the young lady went in. She was diagnosed with leukemia, early stage. 10 months later, she rang the bell. She was clear. Well, that was in that Lancaster, Lebanon thing I was talking about before. That claim cost that school district $700,000. And I said to the guy I work with, because he said to me, that was a bad year. I said, well, that 700 made it a bad year. He said, yeah. I said, but you don't care, do you? And he said, no. We solved a major problem.
Mm-hmm.
Bingo. Early detection.
Yes.
Primary care done properly helps drive early detection. Early detection saves complications. It saves heartache. It's worth it.
So, can you give, and obviously this podcast is strictly for informational purposes only. Every case is going to be different, but what kind of savings on a health plan trend have you seen by implementing this kind of program into the workplace?
Yeah, there's a case study that we normally use. It's a 2,500 life municipality that uses Vitable, has had them now for, I guess, we're probably going into their 5th year. Again, the trend factor suggests they should be spending now probably something like $27 million on their plan, very rich plan. In fact, they're way below that. They're saving on average somewhere around $2.5 to $3 million a year. And that, if you look at it, the only reason is because this primary care program is there. It just makes so much sense. So yeah. I guess there's no good reason not to.
Yeah, and that makes sense, right? Because you're taking utilization away, but you figure the employer at that level is saving 10 to 12% of what their spend is, right? So even if you move that back down and a smaller company and let's say a smaller company is spending $3 million a year in premiums, right? They're probably going to save maybe $200,000-$300,000. I mean, just ballpark. I mean, this is just for information, anyways. But this is just kind of give an idea and paint a picture of what kind of cost savings that are involved by taking a company and trying to shift some of that utilization to another portfolio, so that way it doesn't drastically increase costs over a period of time, because obviously employers are facing that premium.
Yeah. What we're seeing on average is a 3-to-1 or more ROI on the back end. Normally, the cost of the program is recouped in savings within about 3.5 months in each year. It works simply because it appeals to the people. It gets them engaged because they have no obligation. That's even small dollar copays today are a detriment to good care. People are stressed. They're stretched. They just don't want to spend money. And if they go, then they think, well, what if they find something and then I got? We take that away. Let's get them evaluated. Give them the comfort of knowing, hey, I just had my visit. I'm in good shape. That's good stuff.
No, and this has definitely been great information. I know you've had a tremendous amount of years and experience that comes to this, so there's a lot of intellectual knowledge. And I know when we were trying to cross notes, I'm a big scuba diver, and you did a lot of boating. But I'm curious. Well, one is the Chesapeake Bay. Is that the same bay that the naval base is out of?
Oh yeah.
Yeah. So
well, and Annapolis, the whole bit. Yeah.
Oh, yeah.
When we rode the boat, we docked in Baltimore. That was our port of call.
Yeah.
We stopped. There was a big marina there that we were in, and our favorite trip, we'd like on a Saturday morning, we'd go off because where we had the boat, we were in the midst of everything in Baltimore. I mean, the stadium was right across the water. It was great.
Mm-hmm.
Go up Saturday morning, take a nice leisurely ride down, go under the Bay Bridge, and take a ride down to Annapolis and spend the weekend there. Or there were tons of places. But what's really, really nice about boating on the Chesapeake is even if you hit some weather, the waves don't get real big. You get out in the Atlantic, it's a whole different world out there.
Sure.
And,
yeah.
The Bay was great. So we loved that boat. But as the kids got older, they didn't want to be there. They wanted to be at home with their friends. And as they always say in boating, the two best days are the day you buy and the day you sell.
You sell it. Yeah. So moving from Maryland to Pennsylvania, what kind of boating opportunities are in Pennsylvania now?
Well, we actually were living in Pennsylvania, but Maryland was the place we wanted to run the boat.
Oh,
up here in Pennsylvania, there's a lot of big lakes, but now you're talking about, little motorboat type stuff. And what we liked about our boat, we had a sleeping capacity for 8 people aboard that thing. So
that's good.
We could take a nice group and have some fun. And
so just to wrap up, obviously you work with employers, you work with brokers, insurance agents. They listen to this podcast too. But if anybody needed to reach out to you and say, hey, I want more information on this. Hey, can you give us some case studies? Can we get a proposal? How would they reach out to you and get that information?
Well, there's 2 ways. My email, which is very long. My wife was totally opposed to my doing my email this way, but I did it anyway. It's G Blaum, BLAUM, at innovationprogramsllc.com. So it's a mouthful. The easier way is to just call me. My cell number is 484-818-1006.
That sounds great. And then you and I connected on LinkedIn. So anybody listening to this, if you didn't get a chance to jot those 2 things down for contacts, reach out to Gary, G-E-R-R.
On LinkedIn, it's Gerald, Gerald, and Blaum, Blaum.
Yeah, so hopefully our audience took some golden nuggets from this. Maybe we'll have you back with some updates and see what kind of trends are. And I appreciate your time.
Hey, thanks, Butch.